All right, looks like it's 7 o'clock and the recording has started. So we'll get things started here. Brian, do you read this slide here for those calling in?
We can go through it real quick. Just make sure everyone is aware of. I would keep track of people. So again, welcome everybody. If you're calling in by telephone and can't see the screen, you're muted. And if you would need to unmute to speak to the group, press *6 to mute or unmute your phone. On the laptop, you can use the controls at the bottom of the screen, and we request that only those who are speaking to the group unmute their devices. Generally, it's the P&T committee members, and then we reserve questions until the end of the presentation. And public comment, again, there's a time specified for that. Please enter in the chat your name and your affiliation, the company you work for, or if you're with a university or anything like that, just so we know who's on the meeting. If you're calling in and you can't enter on the chat, please send an email to medicaidpharmacy@utah.gov with your name and affiliation. And as always, we welcome feedback.
Perfect. Thank you so much, Brian. The first item on our pretty packed agenda today is review and approval of the last meeting's minutes, which were sent out. So that was September 20th, the minutes there.
And I can present those if that would be helpful to everybody. There it goes.
I would motion to approve.
Thank you, McKay. I will second that. And all in favor, say aye.
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 Any opposed? All right. Any abstentions? And I believe that motion carries. Thank you.
Clinton, did you raise your hand for approve or oppose? The timing of it wasn't, I wasn't sure.
Sorry, I'm slow. Yes, I approve.
All right, thank you.
Excellent. I believe the next item on our agenda is our annual training from Tony Patterson.
And I don't see Tony on the meeting yet, and so maybe we can proceed with the next part of the agenda and circle back to the annual training.
I was looking as well. Perfect. I just wanted to give that opportunity. So I believe we have Dr. Nguyen for a DUR board update.
Thank you. So in November, the DUR board has met to discuss about the cystic fibrosis medication experience. We invited Jeff Zobel. He is a pharmacist at the Primary Children. He has shared with us the experience that he has specifically with Trikafta, how the medication have helped a lot of CF patients significantly. Also, we have reviewed the acute hereditary angioedema therapy treatment. And Jen have also gave the board the update status on the House Bill 178 about pharmacist prescribing status. And we also talk about the early refill policy that the pharmacy team has recently updated. The board will meet in December to discuss about the prophylaxis for HAE and also about the parathyroid hormone. Thank you.
Thank you so much. And the next item on our agenda, we have Dr. Heath talking about our antiretroviral combinations.
Good morning. Can everyone hear me okay? All right, let me just share my screen. Can you see the slides now? Oh, wait, they're taking a moment.
Yep, we've got them. Thank you.
Okay. So today we will be reviewing the fixed dose antiretroviral combination products for the prevention and treatment of HIV. This presentation provides an overview of the report. Please refer to the full report for details. Once HIV infection is detected, lifelong treatment with combination antiretroviral therapy is recommended to reduce morbidity and mortality. This presentation addresses the 23 FDA-approved fixed-dose combination products for HIV-1 treatment or prophylaxis. For the purposes of this presentation, I will be referring to combination products using mostly their brand names. This slide and the next lists the antiretroviral drugs contained within each product and shows the most commonly used three-letter or number abbreviation for the generic drug names on the right-hand side of the column. During the presentation, sometimes I will use the short abbreviations on slides when I'm referring to a single antiretroviral drug. For example, ABC is the abbreviation for abacavir. Within this table, there are 14 fixed-dose combination products that can be used as a single tablet regimen, or STR, for the treatment of HIV. One exception is Cabenuva, which is the first long-acting injectable HIV product that can also be used as a complete regimen like the STRs, but it's an injectable. For simplicity, I list it under the STRs. Available antiretroviral medications work by disrupting the HIV replication or maturation cycle at various steps. As shown in the table, the STRs fall into three main groups. STR Group 1 at the top includes 7 products that contain an integrase strand transfer inhibitor, or INSTI, in combination with either 1 to 2 nucleoside reverse transcriptase inhibitors, or NRTIs, which are those in the orange text, or with 1 non-nucleoside reverse transcriptase inhibitor, or NNRTI. These are INSTI-based products include Biktarvy, Triumeq, Genvoya, Stribild, Dovato, Juluca, and Cabenuva. 2 of the products, Genvoya and Stribild, also contain cobicistat, which is a pharmacokinetic enhancer that boosts the levels of the INSTI elvitegravir. Note that 3 of these complete drug regimens contain 2 drugs rather than 3 drugs. STR Group 2 includes 6 products that contain an NNRTI in combination with 2 NRTIs. These products include Delstrigo, Atripla, Simfi, Simfi-Lo, Odefsey, and Complera. Simfi and Simfi-Lo differ from each other only based on the strength of efavirenz. Simfi contains the higher strength of 600 milligrams, while Simfi-Lo contains 400 milligrams. STR Group 3 protease inhibitor, or PI-based products include Simtuza. Simtuza contains the PI darunavir that is boosted by cobicistat plus 2 NRTIs. This next slide shows the remaining 9 products. These are fixed-dose combinations that must be combined with additional agents to make a complete drug regimen for treatment of HIV. In other words, they are used among multi-tablet regimens. The first group are commonly used products that contain 2 different NRTIs. Sometimes these are referred to as backbones within the combination antiretroviral regimens. There are 5 dual NRTI products: Simduo, also called Temixis, but I will use Simduo in this presentation, Combivir, Descovy, Epsicom, and Truvada. Notice that Descovy and Truvada differ from each other in terms of the tenofovir prodrug they contain. Descovy is the only dual NRTI that contains tenofovir alafenamide, or TAF, whereas Truvada contains tenofovir disoproxil fumarate, or TDF. Simduo also contains TDF. There is one triple NRTI product, Trizavir, that contains abacavir, lamivudine, and zidovudine. There are 3 products containing a PI with a pharmacokinetic enhancer. These are Evotaz, Kaletra, and Prescobix, which each contain a different PI, atazanavir, lopinavir, and darunavir, respectively. As you know, there are many other antiretroviral products for treatment of HIV that contain a single drug. These can be taken together or combined with some of these fixed-dose combination products to form unique combination antiretroviral regimens. Various studies have demonstrated that single-tablet regimens compared to multi-tablet regimens and once-daily versus twice-daily regimens improve adherence to treatment, and this may also improve disease outcomes. It is generally encouraged to use these combination products when feasible to reduce regimen complexity and pill burden. Regarding the FDA-approved indications for these products, there are some slight differences. Most of the STRs are approved to be used as an initial complete regimen for treatment-naive patients with HIV-1 and to replace a previous regimen in treatment-experienced patients with HIV-1 in certain circumstances. There are 2 exceptions. 2 of the 2-drug INSTI-based products, Cabenuva and Juluca, are only indicated as a replacement regimen in patients who are virologically suppressed. As I already mentioned, the FDCs that are not STRs are indicated for use in combination with another antiretroviral agent for the treatment of HIV-1. 2 of these products that contain dual NRTIs, Descovy and Truvada, are also indicated as pre-exposure prophylaxis against sexual acquisition of HIV-1 in adults or adolescents. Descovy has a narrower indication, as it is not for use in people at risk due to receptive vaginal sex, unlike Truvada. Most of the products are indicated in children once the child has reached a certain weight or in some cases age. Kaletra is approved for the youngest age, as young as 14 days old. There are 4 products only indicated for adults: Dovato, Delstrigo, Juluca, and Cabenuva. There are unique formulation characteristics worth noting. Cabenuva, the long-acting injectable, is given every 4 weeks. Kaletra is the only product available as an oral solution. The different size of tablets is also a factor to consider for some patients. Most products can be taken once daily, except for those containing zidovudine, Combivir and Trizavir, and Kaletra when it is used in certain populations. Some antiretrovirals are not available as a single ingredient product. Thus, if someone wanted that antiretroviral, they would be limited to the fixed-dose combination product. To the best of my knowledge, these include Bictegravir, that is only available within Biktarvy, lopinavir, available as Kaletra, Elvitegravir, available as Genvoya or Stribild, and possibly also tenofovir alafenamide, which is available in various FDCs. Most of these products are still brand only, but there are a handful that have a generic available as listed on this slide. Okay, so now I will transition to talking about guideline recommendations. The US guidelines reviewed are from the US Department of Health and Human Services, or DHHS, or the International Antiretroviral Society US panel, or IAS. DHHS has guidelines for 3 populations: adults and adolescents, which includes children with post-pubescent sexual maturity ratings, the pregnancy and perinatal population, and pediatrics, which is intended for children with a sexual maturity rating of 3 or below. The DHHS guidelines are regularly reviewed and have been updated within the past year. The IAS guideline, intended primarily for adults, was updated less recently in 2020. I will use some terminology for the recommendations that was developed by DHHS. The preferred regimens are those given the highest recommendation and intended to apply to most, but not all patients. Alternative recommended options are considered to have some disadvantages compared to the preferred regimens, which may be related to efficacy or safety concerns like drug interaction risk, pill burden, or barrier to the development of resistance. Alternative regimens are appropriate initial options for certain patients based on their unique characteristics, such as patient preference, pre-therapy drug resistance, co-infections like tuberculosis, or other patient comorbidities. I will focus mostly on DHHS recommendations for the initial treatment of HIV-1, that is for use in treatment-naive patients. For all populations, adults, children, and during pregnancy, a 3-drug regimen is recommended. For non-pregnant adults and adolescents, preferred 3-drug regimens include an INSTI, either bictegravir or dolutegravir, in combination with 2 NRTIs. For children, preferred regimens vary based on their age and their weight. Refer to the report for details in each population. In general, recommended regimens include an INSTI NNRTI or boosted PI with plus 2 NRTIs. During pregnancy, preferred 3-drug regimens include a boosted PI or INSTI, either dolutegravir or raltegravir, plus dual NRTI. Following a recent paradigm shift for non-pregnant adults and possibly adolescents, certain evidence-based 2-drug regimens are also recommended options for initial therapy. One of these is a preferred regimen available as an STR, Dovato. However, Dovato is not recommended when pre-therapy HIV RNA is above 500,000 copies per milliliter, or if someone also has chronic hepatitis B co-infection, and it requires pre-treatment genotypic testing for resistance. This next few slides show FDC products that could be used to satisfy DHHS recommended preferred or alternative regimens across the 3 major populations. Children with a sexual maturity rating 3 or lower, shown in the first 2 columns. Non-pregnant adults and adolescents with a sexual maturity rating above 3, shown in the middle 2 columns, and pregnancy in the last 2 columns. Within each section, green X's within the leftmost column denote that they could be used for a preferred regimen, and the black X's in the rightmost column show that they could be used for an alternative regimen. INSTI-based FDC products shown on this slide are among preferred or alternative DHHS recommended regimens for initial treatment, except for Cabenuva and Juluca, which are options later for virologically suppressed treatment-experienced non-pregnant adult and possibly adolescent patients. Biktarvy, which is a preferred option for adults and some children. Triumeq is a preferred option for all 3 populations. Genvoya and Stribild are alternative options for certain populations. Moving on to the NNRTI-based and PI-based single tablet regimens, as you can see, unlike the INSTI-based STRs, all of these products fit into DHHS alternative regimens rather than preferred regimens. This final slide shows the FDCs that are to be combined with other antiretrovirals to comprise a complete drug regimen. These include the boosted PIs and dual NRTI backbones. Among the boosted PIs, Kaletra is a preferred option for some pediatric patients and an alternative option for others. The other boosted PIs serve as alternative options in certain patients. DHHS notes that for adults and adolescents, darunavir, as in Prescobix, is generally favored over boosted atazanavir, as in Evotaz. Regarding the NRTI backbones, among children, Epsicom and Descovy are among preferred options for certain children, while Combivir or Truvada are among alternative options. For non-pregnant adults or adolescents, Symduo, Descovy, and Truvada are preferred options, and the remaining dual NRTI combinations are alternative options. Epsicom, Symduo, and Truvada are preferred options during pregnancy, while Combivir and Descovy are alternative options. The triple NRTI product, Trizavir, is not listed as a preferred or alternative option for any population. Regimens that only contain NRTIs have demonstrated inferior efficacies to some other options, and their use is generally not recommended. I want to briefly mention the other US-based guideline by IAS to contrast it with the DHHS guideline recommendations for adults and during pregnancy. In general, the recommended regimens are similar. There are a few notable differences. First, IAS considered regimens containing abacavir to be less favorable. This would apply to products like Triumec and Epsicom. Some downsides of these products containing abacavir are that they require testing for the HLA-B star 5701 allele before their use, so they can't be rapidly started. Also, some observational studies, but not all, have demonstrated an increased risk of myocardial infarction associated with abacavir. Secondly, regimens containing elvitegravir or atazanavir, which are among some DHHS alternative options, are not listed in the IAS guideline. Elvitegravir does have some disadvantages compared to the other INSTIs, bictegravir or dolutegravir, as it is co-formulated with cobicistat, making it more prone to drug-drug interactions. There are a few differences between guidelines regarding the dual NRTI backbones recommended during pregnancy. Regarding prophylaxis for HIV acquisition, the two drug-containing FDCs, Truvada and Descovy, are recommended for pre-exposure prophylaxis, or PrEP. Truvada is recommended for all at-risk populations by both guidelines, and Descovy is recommended in the more recent IAS guideline for men who have sex with men with risk factors for TDF toxicity. Post-exposure prophylaxis, or PEP, is a potential off-label use for some FDC products. This is a 28-day regimen that is started after a high-risk exposure. The Centers for Disease Control and U.S. Public Health Service guidelines on PEP are a bit dated. The last was published in 2016. However, FDCs that could be used to satisfy all or part of their recommended 3-drug PEP regimens include Truvada, Kaletra, Combivir, Symduo, and Stribild. After searching for head-to-head randomized controlled trial evidence among the FDCs for initial therapy, or PrEP, we found 11 unique comparisons. For the sake of brevity, I'm not going to go into much detail about this evidence since it is largely taken into account by guideline recommendations. Refer to the full report for details. Most studies demonstrated non-inferior efficacy between the comparisons based on a primary outcome of achieving an HIV viral load below 50 copies per milliliter by 48 weeks or later. This slide mentions comparisons that included a DHHS preferred option for non-pregnant adults. Triumec, a preferred option, shows superior efficacy to Atripla, a DHHS alternative option, consistently across analyses between 48 weeks and 144 weeks. Triumec also showed superior efficacy to Simtuza, an alternative DHHS option, in an intention to treat analysis, but not the other analysis. Triumec and Biktarvy, both among preferred options, demonstrated non-inferior efficacy. Likewise, Truvada and Descovy, among the preferred options, demonstrated non-inferior efficacy when both were combined with dolutegravir. In the trial comparing preferred options, Triumec and Biktarvy, nausea occurred significantly more frequently in the Triumec arm. One study I found was conducted among pregnant patients comparing Descovy and Truvada, both in combination with dolutegravir. This study found fewer adverse pregnancy outcomes, that is the composite of stillbirth, preterm delivery, low birth weight, in the Descovy arm compared to the Truvada arm. One study compared Descovy and Truvada for PrEP in a highly treatment-adherent population of cisgender men and transgender women. This study demonstrated non-inferior efficacy between Descovy and Truvada for preventing HIV infections. The renal and bone safety profile favored Descovy. Across the 23 products, there are numerous warnings and precautions, including black box warnings for use. Please refer to the full report for details. The safety profile of the fixed-dose combination products is characterized by potential adverse events specific to each individual component. This table mentions a select few of them organized by drug class. As a class, INSTI-based products are generally well tolerated. The most common adverse effects are GI or CNS related. Compared to other classes, INSTIs are associated with a bit more weight gain. Within the NRTI class, zidovudine is arguably the least well tolerated. It carries a greater risk for class-associated toxicities than other NRTIs. It also has a risk for bone marrow suppression and myopathy. As I mentioned before, testing for the HLA-B star 5701 allele is required for use before use of abacavir due to the risk for potentially fatal hypersensitivity reactions. Abacavir-containing products are also contraindicated for patients with moderate to severe hepatic impairment. For comparing the tenofovir prodrugs, in additional clinical trials, TDF is associated with more frequent renal adverse events than TAF, and greater declines in bone mineral density than with TAF. Although meta-analyses suggest that the greatest difference in these effects are observed when TAF and TDF are combined with a pharmacokinetic enhancer. Efavirenz carries a risk for neuropsychiatric events and rashes. Adverse event-related treatment discontinuations were more frequent with efavirenz containing atripla versus other active comparators. Within the NNRTI class, doravirine may have less frequent class-associated effects. Adverse effects associated with the PIs include poor GI tolerability, increases in lipid parameters, hyperglycemia, and rashes. Both boosted darunavir and atazanavir seem to exhibit a lower risk for the metabolic events characteristic of older PIs, including lopinavir. In large cohort study, boosted lopinavir and darunavir, but not atazanavir, have been associated with an increased risk of cardiovascular events. Atazanavir labeling warns of the risk for developing chronic kidney disease and asymptomatic indirect hyperbilirubinemia. Evotaz containing atazanavir is not recommended for patients with hepatic impairment. Now that was a lot of information. In summary, relative preference for initial regimens in the DHHS guideline for non-pregnant adults is generally congruent with our findings from the head-to-head evidence review. The fixed-dose combination antiretroviral products are an important treatment option for people living with HIV. Some products are additionally recommended for preventing HIV. Overall, HIV treatment decisions are made based on patient characteristics or preferences, though the DHHS preferred initial options for patients are intended to apply to most patients. Treatment guidelines encourage a regimen with higher tolerability and greater simplicity to promote adherence. So on this slide, I list some options for recommendations about placement of these products on the Utah Medicaid Preferred Drug List, or PDL, that the P&T committee may consider. The board may consider recommending trizavir as non-preferred on the PDL. Sorry about that. The board may consider recommending for PDL preferred status at least one STR product and at least one non-STR fixed dose product, which could be used to satisfy a DHHS guideline preferred initial regimen for the treatment of HIV-1 for each of the three major populations: children, pregnancy, and adults. The board could also consider recommending for PDL preferred status at least one additional STR that is from a different antiretroviral class than that selected to fulfill the previous recommendations in order to offer some variety in PDL preferred STRs. Also, the board could consider recommending that at least one US guideline recommended fixed dose combination product for PrEP is preferred on the PDL. We pulled pharmacy claims for these products between the start of 2019 and September 2021. We also queried medical claims for utilization of Cabenuva. So far in 2021, there were 178 unique patients in the fee-for-service population that filled a prescription for one of these products. Very few claims were for people under 18 years old. In total, there were 7 claims in 2021. Products filled among those less than 18 years old included Truvada, Kaletra Oral Solution, and Biktarvy. Overall, the top 5 most common products in order of frequency of patients were Biktarvy, Descovy, Truvada, Triumeq, and Genvoya. There were numerous other products without any utilization in 2021, though it's important to consider that this could be due to various factors such as current preference on the PDL. So thank you for listening, and please let me know if you have any questions.
Thank you for that extensive review. Really appreciate it, along with the accompanying large PDF. So very large topic. Thank you so much. I believe next on the agenda, we had some public comment. Dr. Caitlin Nguyen, please go ahead.
Good morning. Can you hear me?
Sure. And just a quick reminder, we do limit public comment to 3 minutes. So.
Thank you. My name is Caitlin Nguyen. I'm a ViV Healthcare MSL, here to speak on the importance of open access for guideline-supported single tablet regimens, or STRs. HIV continues to be a public health challenge with 1.2 million people living with HIV and 37,000 new HIV diagnoses in 2019. The national goal is to reduce new HIV infections as much as 90% by 2030. Despite the importance of ART adherence, rates are suboptimal in the Medicaid population. The high pill burden of a multi-tablet regimen, or MTR, is associated with decreased adherence and is a strong predictor of treatment discontinuation. Poor adherence may lead to incomplete viral suppression, drug resistance, disease progression. Studies have shown patients on STRs have higher adherence, better outcomes compared to MTRs. In such a vulnerable population, guideline-approved STRs such as Triumeq, Dovato, Juluca, and Cabenuva should be made available. Triumeq and Dovato are recommended as initial regimens. Triumeq demonstrated superior efficacy in the registrational trial and is the only DHHS preferred STR in pregnancy. Dovato is the first 2-drug regimen for treatment-naive patients and has been studied as first line in test and treat with a 92% observed suppression at week 24. In suppressed patients, guidelines recommend switching to simplify dosing, prevent drug-drug interactions, and/or decrease toxicities. Only 3 STRs have A1 rating in switch: Juluca, Dovato, Cabenuva. Juluca is the first 2DR to be approved for switch. Dovato's label expanded to include switch indication. Cabenuva is the first complete long-acting regimen, strongly recommended by DHHS and IAS USA guidelines. With a novel option of monthly dosing, the panel noted that Cabenuva may be beneficial in improving quality of life for patients who struggle with pill fatigue or fear of disclosure and stigma associated with daily oral pills. ART should be individualized based on resistance, tolerability, polypharmacy, and comorbidities. Having access to the right ARVs at the right time is crucial to achieve optimal health outcomes and prevent further HIV transmission. STRs may improve adherence and reduce the risk of transmission and resistance. I ask that you consider ensuring this access by adding Juluca, Cabenuva, Triumeq, and Dovato, all as preferred, so as to align the PDL with guidelines and allow providers to customize regimens with the goal of optimizing clinical outcomes for your members, ultimately helping to end the HIV epidemic. Thank you for your time.
Thank you.
Hello?
Oh, yes. What's that?
This is Dr. Rosado from the University Hospital HIV Clinic. Thank you for the invitation. I know I have 3 minutes, so I'm going to be really short about this. So I have here also Christine Jamijan, a PharmD, and actually she's an HIV pharmacist. We have been listening to the whole presentation. So one of the recommendations that we have is that Trisivir, that is basically 3 nucleoside analogs combination. We should discontinue that from being available. I think not too long ago, we got a patient, a provider that is not very familiar with HIV management, and the patient was taking Trisivir. It should not be used as a sole agent to treat HIV. We never use here Trisivir. I don't know in what kind of situation that should be done. I think my personal opinion is that we should discontinue Trisivir from the formulary. There was the rapid start. That is something new that we want to do, is to start people on HIV therapy as soon as they are diagnosed or as soon as they come to the clinic, the first visit. There is many factors involved in that. We need to do HIV viral load, CD4 count. We need to know the renal function, and also if they have hepatitis B infection or not. But there is this regimen with Biktarvy that have been recommended as the initial regimen before you get the results of all those tests. So it's another thing that we like to mention here. And I think in general, the presentation was excellent. We just want to be sure that the double agents are included, that the injectable Cabenuva should be included too. This is going to be the future. This is the beginning of a future of injectable HIV therapy. And we should start with that. Cabenuva probably, I mean, what I know, is probably going to change to every 2 months next year. There is a data that shows that is equivalent to 1 month injection. And it's true, for some patients, the injectables are going to be a great option for them, people who don't take pills all the time. And I think this will help a lot. So saying that, so anything else, Christine, that you...
No, I mean, in addition to Biktarvy for rapid start, also Descovy, Tivicay, or Truvada Tivicay is also an option, and Simtuza, which is a combination of the 4 drugs that include boosted PI, is also indicated for rapid start.
And the other thing, I know that Truvada is generic and Descovy is not, and obviously Medicaid prefer generic agents. But I think Lauren mentioned that with Descovy, there is less renal toxicity and bone toxicity. Remember that we have a large population of HIV patients that are aging, getting older, comorbidities, diabetes, hypertension, cardiovascular disease, hyperlipidemia. And for those people, Descovy probably is the best choice instead of Truvada.
And that's time. Thank you.
We're at the
And
minute mark, but we can, if the committee would, others like to hear kind of the end, but I think we were talking about the renal differences between TDF and TAF.
mm-hmm. Yeah, and I'd actually like to hear that too.
Yeah, so that would be great. Dr. Rosado Santos, if you want to just kind of, you are able to conclude any last points there.
So it's just to make it easy for people when they, obviously you might have some, prior authorization with Descovy versus Truvada, but maybe you should have an easier way for us to get Descovy when we feel Descovy is the right choice for our patient. And mainly, talking for HIV and also post-PrEP, HIV prevention, that might be another thing. So we see all kind of people for HIV prevention, younger people, that Truvada will be okay, but also we see people 50, 60, even 70s that are taking PrEP, and Descovy should be the agent for that population. Thank you very much.
Yep. Thank you, Dr. Rosado Santos, and thank you, Dr. Jamijan. I just wanted to quickly address a couple of things that you mentioned. One is Trizavir, and we have had Trizavir non-preferred on the PDL in accordance with P&T recommendations since these drugs were put on the PDL in 2017. it can still be obtained through prior authorization. To my knowledge, we don't have anyone receiving it through Utah Medicaid. And when Utah Medicaid covers drugs, we're required to cover any drug that meets certain parameters as CMS definition of a covered outpatient drug, but we do have it as non-preferred, so it does require that prior authorization. And so that's kind of the tools we have to limit its use. And again, hopefully not a lot of people are going to be using prior authorizations for that drug. You also mentioned the Descovy and Truvada for PrEP and PEP. We do have both of those agents unrestricted preferred on our preferred drug list.
Thank you.
Thank you for those clarifications, Brian. And yeah, just looking through the utilization data, I didn't see any Trizavir either. So that seems consistent. And then next on the agenda, we had Natalie Rose.
Hi, can you hear me?
Yes.
Perfect. Thank you for having me this morning. My name is Natalie Rose. I'm a medical scientist with Gilead. Biktarvy is indicated as a complete regimen for the treatment of HIV-1 in adult and pediatric patients. It's the smallest 3-drug, INSTI-based, single-tablet regimen available. With durable efficacy, safety, and demonstrated tolerability, Biktarvy is supported by extensive clinical trial data and more than 2,200 people living with HIV of various age groups, genders, ethnicities, including children and adolescents, as well as women and African Americans. This year, the FDA approved a label update for Biktarvy, which now includes a specific indication for use in those greater than 65 years of age, and more recently expanded the indication for use in children weighing at least 14 kilograms. Biktarvy is a recommended initial regimen for most people living with HIV in all major U.S. guidelines, including DHHS and IAS, and can be used for rapid start before baseline testing results are available. As mentioned, Biktarvy is a single tablet complete regimen. Individuals on a single tablet are significantly less likely to discontinue treatment compared to patients on a multi-tablet regimen. And due to increased adherence and lower discontinuation rates, single tablet regimens are associated with higher rates of viral suppression. And this improved HIV control has been shown to decrease rates of hospitalizations and result in lower overall healthcare costs. We respectfully request that Utah continue to allow unrestricted access to Biktarvy and list it as preferred. I'm now going to move to HIV prevention. Descovy or FTAF is indicated in at-risk adults and adolescents weighing at least 35 kilograms for pre-exposure prophylaxis to reduce the risk of HIV infection from sexual acquisition, excluding individuals at risk from receptive vaginal sex. I want to review some key differences of FTAF versus FTDS for HIV prevention. First, TAF, or tenofovir alafenamide, is more efficient in getting the active drug, tenofovir diphosphate, into the target molecule, delivering 4 to 7-fold higher intracellular tenofovir levels. FTAF achieves an EC90 more rapidly than FTDS. Specifically, a single dose of TAF leads to concentrations of the active drug above EC90 within 1 to 2 hours, versus 3 daily doses of FTDS to surpass a protective level, and actually has a longer durable EC90 after the last dose, specifically 16 days. Lastly, FTAF also provides significantly less impact on EGFR and bone mineral density. The U.S. Preventative Task Force released a grade A rating recommending PrEP for the prevention of HIV infections, recommending that clinicians offer PrEP for effective antiretroviral therapy to persons who are at risk of HIV acquisition, specifically providing medications that are deemed medically appropriate for them. So overall, FTAF has proven pharmacokinetic benefits, as well as provides significantly less impact on EGFR and bone mineral density, while still maintaining efficacious results in preventing HIV infections. Given these benefits and the grade A rating that I recommended,
that's time. Thank you.
Available. Thank you.
All right. That is the last of the scheduled comments on the agenda. So I think we will open it up for discussion, and if any committee members have further questions, points of clarification. start discussing those now. I think the simple one, I don't see any reason to change the 2017 recommendation for Trizavir, unless someone feels differently there.
I agree with that. You know, we have an existing recommendation specifically to non-prefer that drug, and I agree with continuing that for Trizavir. I don't think we need a motion because we have an existing recommendation.
Brian, how do you like to, do you want specific recommendations for, you know, PrEP, for PEP? You know, do you want it broken up into that, do you think? Or how do you see this being the most effective?
Generally speaking, and this is broadly across any topic, my preference is to have recommendations that are not drug specific, because data changes over time. We get more information, and you know, we don't want to be in a position of a specific drug being recommended as preferred, and then later we find out, you know, it causes people's arms to fall off or something. And I mean, that's a wild example, but I like having the options of, you know, for specific conditions, having at least one or two or whatever the recommendation is, agents for treatment or prevention. And I mean, looking at our current PDL, we do have a lot of options, and I don't anticipate making drastic changes to that. But I think the U had some good slides with some of their recommendations too, that I thought were good.
Yeah, as I'm reading through the recommendations from the College of Pharmacy, one STR that is in the initial treatment group, one 2-drug FDC that's preferred, that's DHHS preferred for initial treatment. Mm-hmm. And then I think those two are very clear and compelling recommendations. Mm-hmm. I think at least one recommended drug in the U.S. guidelines for PrEP is reasonable. I think the one that I think maybe is less clear, and whether we should discuss, as I'm looking at their list of recommendations, is whether we need to make this recommendation about alternative regimens or not.
Right. And on the single tablet regimens, I almost think that we would, at least 2 would be good, as opposed to at least 1. Again, what we have in practice is much more than that, but
yeah, I agree with you, Brian. I think yeah, we've got 2 would be a good idea. I think so how do you phrase it so that you don't end up with you know, you would want a different, it's almost like you would want I'm just thinking, do we want 2 different backbone, 2 different drugs that are different based products.
Non-overlapping.
Yeah, non-overlapping.
Or at least different
About
backbones.
how you would want to phrase that. I'm while trying to give flexibility, like you're suggesting, Brian.
What if it was at least 2 single tablet regimens with different, or single tablet regimens with at least 2 different backbones? Would that?
Yeah. That's I think what I'm getting at.
Mhm.
Would that address kind of what the concerns were from the university HIV clinic, where they want to ensure, what I heard was that they want to ensure that the flexibility is there to have something that clinically is going to be able to treat those individuals with comorbidities, that aging population, I think specifically with renal impairment. So as long as that recommendation for that second agent, that second alternative, and I don't understand the pharmacokinetics enough to know the different backbones as far as which that would be, but specifically calling out Descovy in order to ensure that option was available. I want to make sure that our recommendation is able to provide that flexibility for individuals with those comorbidities. And so, Clinton, I don't know if that's what you were kind of getting at.
Well, I was getting at you wanted the 2 different backbones just because of varying resistance patterns and
Sure.
and response to therapy, but I think your point is about the TAF versus the TDF, and I think probably having an option that is available for renal impairment is a reasonable suggestion as well.
Mm-hmm. And one thing to keep in mind with the alternative therapies is I agree that we should probably have some alternative therapies, but when something is non-preferred, the barrier for that is a prior authorization that says this drug is appropriate because they can't use this other drug. That's essentially what the PA process is failure or contraindication to a preferred agent. And if someone has comorbidities that preclude use of a preferred agent, then that would be an appropriate clinical rationale. That said, I think it is reasonable to have alternative therapy options available as preferred as well.
And looking at the claims data, are TAF containing regimens, so Descovy and Biktarvy, are the 2 most claims, at least for 2021, both in claims and number of patients. So it does not appear there's a large barrier to get TAF at the moment, TAF containing combination products. Because I felt the same way, and that was reassuring to me that this seems to be where Medicaid is meeting these claims.
And I assume that's because the Biktarvy and Descovy are on the PDL. I don't have the PDL in front of me, but
yes, they are both preferred.
Yeah.
I believe there's 17 agents in the class that are preferred. Let me just double check real quick.
That's pretty good, Brian.
Yeah, 17.
Okay, so if we're going to try and break this down into recommendations, I guess I can. This is always the tricky part of the meeting here, where you try and say in clear and concise form what we've already discussed.
Crafting the motion.
Yes.
Yes.
Okay, let me go back to those recommendations from the College of Pharmacy. But
the bottom of page 11, if you have your PDF open.
Yeah, there we go. Thank you, Cole.
I can present that too. I'm looking at slide 17. I don't think you guys have this slide.
No, we don't. But yeah, I'm back now to where Cole was talking about and what. Yeah, I'm happy for somebody else to do it too. It felt like we'd kind of come to some conclusions and
Mm-hmm.
yeah, exactly. Yeah, this is what I was looking at in the narrative. Well, not narrative, but the written review as well. So I think I think the question is, do we say 1 or 2 on the STRs? I mean, I think I would favor 2 as well. And then I think we do need at least 1 FDC.
And on the STRs, we wanted at least 2 different backbones, right?
Yeah. And I can state these out fully. I'm just kind of trying to get them out there to make sure there's no more discussion before I do. And then I think we want 1 for PrEP, at least one product. And I don't think I need to say FDC. My inclination was to not say FDC for PrEP, but just say, 1 product recommended in the U.S. guidelines for PrEP. And then the part that the 2 that I was struggling with still that I think we maybe need to clarify is, do we need to say, something about, remind me what the ARV class is on the bottom here? There's 1 STR of a different ARV class. Oh, that's just referring to the different backbone, right? That's all that means. Is that right? Okay. Yeah. Cole's nodding yes.
ARV just stands for anti.
Yeah, anti-right. Got it. So it's the
like PI based instead of.
Yeah, and then RTI. Right. Okay. All right, that makes sense. ARV, of course, antiretroviral. Yes. Sorry for my moment of ignorance.
A lot of alphabet soup.
Yes. Right. But yeah, ARV should have been obvious. Okay.
Sorry, Dr. Sheffield. The other consideration there, an injectable versus enteral forms, that was at least something that was brought up. I don't.
Yeah. Thank you.
It doesn't look to be a difference, at least therapeutically. Obviously, adherence and things would come into play to that. Just something that was brought up that we should.
Right now, I think we only have 1 injectable option, and I think it's kind of new, and we're still learning where its place in therapy is long term. But
yeah, I think yes, it's a nice thing. I think I'm hesitant to say it, to recommend it's on the PDL because there's only 1 option. And then along those same lines, do we need to say something for pediatrics? It's probably not a problem currently.
And I thought as long as we're going with the DHS, HHS guideline preferred, they kind of had different cover that for children, pregnancy, and adults.
Mm-hmm.
But I felt like that those could be separate agents as the.
Sure. It does say in children, pregnancy, and adults. So I can kind of say that in the recommendation, I think cover us there. That's a good point. Okay, well, why don't I start with the things we've kind of agreed on here, and then if we need to add any additional recommendations. So I would make the following motions: that we have at least 2 STRs which satisfy a DHHS guideline of preferred regimen for initial HIV treatment in children, pregnancy, and adults. Have at least 1 FDC, a 2-drug backbone, which could satisfy DHHS guideline preferred regimen for initial treatment in children, pregnancy, adults. And then we have at least 1 product recommended in the guidelines for HIV PrEP.
And do we all, on the single tablet regimen, do we also want to include as part of that
Yes.
Should be at least
Oh.
2 separate backbones.
And then I'll just say that, and at least one of the STRs is that of a different ARV. I'm going to use the acronym here. Antiretroviral class that satisfies a preferred or alternative initial regimen for adults. I like that. I like all of the recommendations on this slide. I think just the only modification is making that first recommendation 2 instead of 1.
Mm-hmm. All right. Is that a motion?
Yeah. I thought I led with this is I motioned that,
yes.
but
I will second that.
All right. So we have a seconded there. All for the motion, say aye.
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 Any opposed? And any abstentions? Sounds like no. The motion carries.
So I think that just the one part that we were still discussing a little bit was the comorbidities part. Do we want to say anything about that in terms of renal? I think was the big point that was brought up by our infectious disease docs. Or do we leave that up to, just when people have prior indications? I mean, they may end up with both of them on the PDL, but do we want to make any kind of recommendation?
I would support a recommendation that has at least 1 or 2. Well, I mean, I guess with what the other recommendations look like, maybe at least 1 that for alternative therapy.
Yeah, and there's a couple meta-analyses of pooled clinical trials. I was kind of looking up here. It's definitely, I'm trying to think the best way to phrase this, but there's certainly, it's pretty clear when there are osteoporosis or CKD concerns that TDF would be we would want to avoid TDF in lieu of TAF would be preferred there. So, and maybe more of these information comes out. So I think we can have a general kind of recommendation there for patients at risk of osteoporosis or CKD progression that an agent with a preferred adverse reaction profile be available. I need to raise that for a motion, but
no, I like that. I think that's fine, Sloan or Cole.
Okay, so I'll state that for patients at risk of osteoporosis, CKD progression, or other known ADRs of these agents, there should be an option to select a preferred agent with reduced toxicity.
I'll second that motion.
Thank you. And all for the motion, say aye.
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 All opposed? And I think Dr. Hoffman put a note in there. She had to go to another meeting, so she will abstain from that vote. And the motion carries.
Do we need to say anything about? I believe the injectable that's not meant for initiation of therapy. Do we need to mention anything with that?
We have a prior authorization on that drug currently that addresses that issue. And I think we're okay on that because we do have that prior authorization.
Okay.
And in our recommendations, we said that we wanted things that would satisfy initial treatment.
Okay.
Which is, I think, important so that you can get started on initial treatment without worrying about prior auths.
Sure.
Yeah, I'm with you, McKay. There's something there because the STR, the abbreviation we use is single tablet, so obviously it's not injectable. But I feel like the DHHS guidelines allow for some movement there. So, and we haven't had anyone. I didn't see any claims for this. Is that what everyone else saw?
Yeah, not yet, it looks like.
Okay.
Would that be on the medical side though? Would those be included?
Oh, great question.
Lauren, do you know if medical claims were pulled as well as point of sale?
We looked in the medical claims and we didn't see anything.
Thank you.
And I just think because the experts over at the U were mentioning that this kind of seems like it's going to be the future, maybe implying that more are going to come out. And so I just want to make sure that these recommendations kind of withstand the test of time or would be.
Mm-hmm. One thing that wasn't really addressed in the meeting, but was discussed when we reviewed these in 2017 is grandfathering. And these are drugs that I don't feel particularly comfortable shifting people around on. If someone's on it, I think they should be able to stay on it. And I would propose that we continue with the grandfathering that we had previously, and I can make that motion. That
Yeah, and maybe do we need to make another motion since we already have one?
It's coupled with other motions that we've superseded, so I feel better if we did.
Right. Yeah.
Repeat. And so I'll make that motion that for fixed dose combination products which includes single tablet regimens, we continue grandfathering patients. If they're already on a drug, they can continue on that same drug.
I'll second that motion.
All for the motion, say aye.
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 All opposed? And one abstention, Dr. Hoffman. All right. So, and then I guess, McKay, just to kind of bring it back to your point there, do we want to have some verbiage in there or recommend the board have some criteria if an injectable is in place? Or I'm not sure the best way. Therapeutically, the advantage is in the adherence, but I'm not sure there's much else. So I guess I'll kind of leave it up to the group there whether we need to comment on this at this time.
I agree with McKay that in the long run, it would be nice, especially if we get more injectables. But I don't know how we're going to recommend that injectables be included without basically saying we recommend this one drug.
And we don't know the future place in therapy either. So it's a slippery slope. And so the prior auth seems to cover that.
And maybe this is something that we revisit in a couple of years.
I mean, we are.
Right. Or you can revisit in the DUR board in the future if there are, a significant number of individuals receiving that medication, whether a PA needs to be either modified or removed at that time within at some period of time within a year. Just review utilization.
Yep.
Dr. Rosado Santos, are you raising your hand?
Yeah, and I sorry, I apologize. I thought that maybe I'm not supposed to interrupt you when your deliberation. Cabenuva, cabotegravir, and rilpivirine is a new treatment indication for HIV. It's new, it is true, it's an injectable. We had to start first, the first one is an oral combination, and it's no problem, we switch to injectable. It is something that we should include. It's an option for patients. I heard somebody say we don't know too much about this. There is a lot of data about this medication, and most likely next year it's going to be once every 2 months. Right now it's one every month. We should include this. This is the future. We are going to have more injectables that will be every 3 months or 6 months. And I think we need to be proactive and have that. We had a lot of patients already asking. Not everybody qualify for this medication. There is some restriction, but we should include this in the Medicaid formulary. If you want to put a restriction, that would be okay, but we should, this is something that we should have as another treatment for HIV. Thank you. Sorry.
And it is available. It does require prior authorization, but it is available. We don't have it as preferred. And again, the barrier or the bar for that is a prior authorization. And as it's not an initial treatment option in recommendations, it seems reasonable to continue to have that prior authorization. And if someone meets those criteria, they get it.
Do you have a specific criteria for the injectables in place?
We have a specific PA form for Cabenuva.
Okay, because most of the time it's just about I like the injectable. I mean, if you have a criteria, I would like to know. Some people say I prefer to have an injectable than to take a pill. If that is part of the criteria, we would like to know that.
Yeah, give me just a second. I'll put up on the screen that PA form just so you can see that.
And I am pasting that into the chat now if anyone wants to click that link.
Thank you, Cole.
And thanks for finding it so fast.
I can make that a little bigger if that helps. So the top stuff, that's header, that's the same on all of our forms. So this is a form that has been vetted by the DOR board.
Okay, thank you for showing me that. Thank you. That makes sense.
So Brian, I think we're covered on that side of things.
All right.
I think so too. Yep, that looks good.
Great. All right, I believe that was, I don't know if Tony Patterson ever joined. I didn't see him.
Yeah, I didn't see him either.
I was looking, but balancing. Let's see. So I believe that was the end of the agenda I saw here. Our next meeting is February 17th, 2022 for non-steroidal atopic dermatitis. I would like to make a motion to adjourn the meeting.
I'll second that.
All right. See everyone in February.
Thank you.
Yeah, I guess all opposed. Yeah. All for aye. Yeah, all opposed. Thank you. We'll get that abstention from Dr. Hoffman, who had to leave early. Thank you.
Thanks, guys.